Hello, Arwa.
Yeah, bro.
Are you there?
Yes.
Okay. Shall we start?
Please.
You hear me and the picture is okay?
Yeah, picture is on and the voice
Okay.
is very clear.
Very good. Thank you very much. Welcome to the Sunday lecture, which is on diseases in the tropics. And the last time we have been dealing with some of the hematological disorders or hematological disease in the tropics, and we tended to explain what is the disease and then how is it different from prevalence, severity, uh, incidence, and so on in the tropics. So we wanted to relate some of the hematological diseases in the tropics to the tropical environment to see if they are different. But we have been taking this opportunity to explain quite a lot of diseases. When you talk about sickle cell disease, we talked about how hemoglobin synthesis has been abnormal, the change of amino acids from one to another. When we talked about thalassemia, it was explained hematologically. So it's when we talked about diabetes, we talked about diabetes proper, and then we looked into it. So we are taking this opportunity to go through a lot of medical conditions generically and in relation to the tropics. So hematological diseases or disorders in the tropics, we have been talking about anemia and talking about sickle cell disease, about thalassemia. The two are genetically inherited. And then we're going to talk about glucose 6-phosphadehydrogenase in this lecture. Okay, if we talk about anemia, what is particular in the tropics? It's prevalence. The anemia burden of the world, 85% of all patients who have anemia reside in Asia or Africa. So it is a very common clinical feature. And in Africa, it is multifactorial. It is multifactorial. That is to say, deficiencies of ingredients of the bone of the hemoglobin. Anemia may be due to infection, which is prevalent. So it is multifactorial. And just to remind you that anemia is not a diagnosis, it's a clinical feature pertaining to or as a mirror to or as a reflection of an underlying disease. So anemia could be due to simple iron deficiency anemia, bleeding disorders. It can be due to B12 deficiency. It can be due to hemoglobinopathies like sickle cell. And it can be due to malignancy. So it changes from the simple iron deficiency up to malignancy can cause anemia. So it is important that we should not say this patient, the diagnosis is anemia. It's anemia due to whatever the cause is. So it's not an end diagnosis. And we remind you that it's very important. The indices of the hematological indices are very important. And nowadays we are living in an era where automation of the laboratory has made it so easy and so accurate that you can get all the indices, be it hemoglobin, white cells, platelets, whatever, prothrombin, all the hematological indices are now being done perfectly well and accurately. Okay, so anemia is common in the tropics. It's multifactorial. Malaria is one of the main causes of anemia in the tropics, and malaria is in the tropics in pregnant ladies and children. They are more affected by the anemia of malaria. And simply, when we talked about malaria, we talked about how to combat and reduce the prevalence of malaria and incidence by using bed nets if available, but early diagnosis and early treatment. And in some who come from a non-malarious area, chemoprophylaxis can also help. So that is malaria, one infection. HIV again, which is common in Africa, is a cause of anemia. 70% of all untreated HIV patients would have anemia. And the way to deal with anemia with HIV is early antiretroviral therapy should be instituted, and this will decrease the chance of anemia. And then you have to look into nutritional deficiencies in HIV because it's a disease which is total in the body, which affects a lot of indices, nutritional indices, and deficiencies of iron, folic acid, and others. So treatment of anemia in HIV is treatment of HIV as it is by antiretroviral and the deficient components of nutrients. Okay, then we talked about sickle cells first. Sickle cell, which is autosomal recessive abnormality, is one of the hemoglobinopathies. And you remember it's autosomal recessive, meaning that you have 1 in 4 chances of being either a carrier or a disease. Okay, so you have 1 chance of being normal if you take the trait from mother and father, which is normal, then you become normal. If you take the disease trait from mother and a normal from father, you become a carrier. If you take the 2 diseased genes, then the patient becomes a sickler, or a sickle cell patient. This is mainly due to an abnormal hemoglobin. This is what we call S hemoglobin. If you want to remember, S hemoglobin is a hard hemoglobin. It's polymerized. Polymerized meaning it aggregates into itself, and it is tougher than the normal A hemoglobin. And in that way, the polymerization, it will change the picture of the RBCs, and it makes it a sickle. And we talked about sickle. The sickle is the rounded or arched plate which is used in harvesting, or like a crescent, what we call الأنيميا الهلالية أو المنجلية. المنجل is a sickle. Okay, so it's hard hemoglobin, and the most important characteristic of RBC is it lives 120 days, so it gives the bone marrow good rest before producing new ones. Number 2 is the flexibility of the RBCs. RBCs, rounded, concave in the middle, and it can negotiate itself through very narrow areas of vasculature. So with that, the RBCs can percolate into the tissues easily, okay? But once you have an S hemoglobin, the RBCs becomes harder, it aggregates, and it cannot negotiate its way, so it blocks. And blockage, because of the aggregation or polymerization of RBCs, is the main pathology of sickle cell. So if we think about one single cause of all the pathologies of sickle cell, is this aggregation and blockage of minor, medium arterial system, which will end with infection, with infarction, with death of the tissues, with necrosis of the tissues, as you get in the head of the femur, necrotic, become necrotic and avascular. So you deprive the tissues from its vasculature because of the blockage, and this what leads to the complications of sickle cell disease. Okay, the other thing is these hemoglobinopathies is genetic, and it is very common in Africa, in Middle East, okay, some parts of Asia. Thalassemia is another genetic, as Dr. Hal Hussein has told you, that it is the most important single genetic defect of humankind. So it is the beta thalassemia is usually fatal in children unless you blood transfuse. And the blood transfusion can save the child, but you should always remember that the blood transfusion it should be accompanied by chelating agents. This is ferrioxamine, which chelates the iron. Because if you load the body with a lot of blood, then you load the body with iron. Okay, so with the same breath of giving blood transfusion, you have to give a chelating agent to help take out the iron. Is this ferrioxamine? Chelation, as you remember, we have defined it as a molecule which attaches to other molecules and mob it out. Like, if you are taking milk, which contains calcium, it binds up to a drug called tetracycline, and it makes a molecule, a bigger molecule, calcium and tetracycline, and that goes in the feces. Okay, so the tetracycline will not be absorbed. So chelation is binding up a molecule to another molecule like a carrier, keeping it attached to it to take it out. So with thalassemia, beta thalassemia, you have to remember to give the the transfusion, which is necessitated, but give chelating agent as well to keep the patient. We have to talk about blood transfusion. Blood transfusion is a life-saving, and it was a miracle to think about giving blood, saving other people's life. But it has to be well controlled. It has to be well matched because any antibodies or the major problems is mismatching, is hemolysis, and renal failure. But with minor mismatch, you may get slight, abnormalities, mild anemia, and so on. But nowadays, the difference between blood transfusion center and another is their ability to do a detailed cross-matching. Unfortunately, this is not the state of affair in Africa because blood transfusion itself is not an easy process. It needs a lab, it needs a blood bank, and it needs donors. And the cross-matching is not easy. Okay, I have witnessed cases of cross-match, and people died because of very severe hemolysis and renal failure. The best is you should have donors, regular donors, okay, being tested very thoroughly from points of view of HIV, of hepatitis B, hepatitis C. They're clear and clean. Okay, these donors, if you are lucky to have a group of them, then this is the best way, rather than having a donor every day from different parts of the society, and this is not always safe. Okay, so blood donation in Africa is a problem, and the availability of blood is, again, something which needs a lot of effort. You remember that there are certain Christians who do not accept blood transfusion. They would rather die than having other people's blood. So you have to be careful, you have to be thoughtful about giving blood transfusion, and it's life-saving in many, many conditions. I mean, one of the main causes of maternal mortality is loss of blood, antenatal and postnatal. So with nothing can be done apart from blood transfusion in these settings. Okay, 3 genetic abnormalities, which is sickle cell disease, Remember, this is because of glutamic acid has been replaced by valine, okay, which changed completely the hemoglobin from A for to S. Okay, so look at the smallest changes in a very long hemoglobin chain, just one amino acid being changed, it changed the life of the whole body. Okay, leaving the patient with an S hemoglobin, which is the cause of death and mortality. So that is one genetic. The second is thalassemia. It's another genetic. And then the glucose 6-phosphate dehydrogenase, which is again genetically, but sex-linked inheritance. Sex-linked, meaning that the abnormal gene is linked to the sex-linked, or the sex gene, or sex chromosome beta. Okay, so that is the glucose 6-phosphate dehydrogenase, and it is the most common enzyme defect in humankind. It is the most common enzyme defect of humankind, with 400 million people having deficiency of glucose 6-phosphate dehydrogenase. But luckily, we have a lot of heterogeneity, okay, of the genetic variation, to the extent that we can have 5 classes of levels of glucose 6-phosphate in dehydrogenase in the cells, in the red blood cells. Okay, these 5 classes, from the most deficient to the over produce enzyme. So the last is the 5, where you have not only a deficiency, but you have an excess, about 150% of dehydrogenase, glucose 6-phosphate dehydrogenase in the cell, which is 50% more than needed. So the disease was discovered by hemolysis. Okay, people started to hemolyze, and it was attached to fava beans. Okay, and it was described then as favism. Okay, the syndrome which is attached by eating fava and causing hemolysis. Fava is food al-Masri. Okay, what we call Egyptian fava is one of these beans which can cause hemolysis. نحن نسميه الفول المصري. في الخليج يقول لك الفول المدمس. alright, لكنه الفول المصري الفول الاعتيادي اللي بياكل الناس في الفطور وكده. Okay, so that is favism, but other oxidant drugs like primaquine, which is a drug used in malaria, primaquine, then again this will initiate hemolysis, which will initiate hemolysis in 6-phosphate dehydrogenase. Then the enzyme defect was discovered. Now, if we look into the countries where this is prevalent, most of the African countries, okay, most of the Middle East countries, and most of areas around the Mediterranean, especially areas like Spain, Turkey, and the like. Okay, so these will have the glucose 6-phosphate dehydrogenase. What is the enzyme? What does the enzyme do that makes the deficiency causing hemolysis? Okay, the enzyme is very important, is the pentose phosphate pathway, which ends with an N, capital NADPH, okay, antioxidant. So the pentose phosphate end up with NADPH, antioxidant, okay, and this antioxidant preserves something called glutathione, which protects the cells against oxidative damage. So if you give a drug like primaquine, which has an oxidative ability, then it doesn't cause anything if the antioxidants are preserved, or there is antioxidants in the RBC. Okay, but if you have this deficiency of the enzyme, then you would not end with a protective mechanism against oxidative drugs or oxidative conditions. Okay, and this will cause the cellular deformity of the RBCs, making it vulnerable to break and hemolyze. Okay, and it makes it more vulnerable to be kept by the spleen and attacked, okay, within the spleen for hemolysis. So you could have an intravascular hemolysis or hemolysis within the spleen. Okay, so this is the hemoglobin becomes denatured hemoglobin. It gets precipitated, and the characteristic bodies which are seen in the peripheral blood film is Heinz body. Heinz body, it's spelled capital H-E-I-N-Z bodies, Heinz bodies. Okay, and the glucose 6-phosphate dehydrogenase, usually the highest level is in young RBCs. But as the RBCs goes down, the glucose 6-phosphate dehydrogenase becomes less and less. So the cells which can be affected more in hemolysis are older cells. Okay, so what are the drugs which people with glucose 6-phosphate dehydrogenase can avoid? Primaquine, we have already said, and the history of glucose 6-phosphate dehydrogenase has been very much linked with primaquine and faba beans. Then drugs like dapsone, you remember? Dapsone is a drug for leprosy. It's a sulfone component. It's a very effective drug up to now in leprosy. Dapsone, nitrofurantoin, which is an antiseptic for urine, and nitrofurantoin. Again, it can cause hemolysis. And cotrimoxazole. If you remember, it's called either septrin or Bactrim, which contains sulfur and trimethoprim. Sulfonamide and trimethoprim is a combination of the two, and they act as a cidal antimicrobial. Cotrimoxazole. This is another one, another drug which can cause hemolysis. So hemolysis is induced or precipitated in glucose 6-phosphate dehydrogenase by primaquine, classically, cotrimoxazole, dapsone, nitrofurantoin. Okay, if you take the drug now, what will happen from the hemolysis? The hemolysis doesn't occur immediately. It occurs within 1 to 2 days and can be so severe, the hemolysis, but it continues, it's self-limiting. It's very likely self-limiting. It can cause some derangement of the renal function, but within 8 days, it goes off. It's self-limiting, which is very, very good. Okay, what are the different types of the hemolysis? There is one type of hemolysis which occurs in the neonatal hemolysis. So how come that a child with neonatal setup will cause hemolysis? It's thought that this is something which, in the mother child who is to be born with glucose 6-phosphate dehydrogenase deficiency, once he's born, he's hemolyzing like neonatal hemolysis, which occurs within the first 4 days, 1 to 4 days. What happened? I mean, what is the mechanism of that? It can be, neonatal jaundice can be so severe that it can cause kernicterus and get mixed with rhesus incompatibility. Okay. The theory is mothers may be having drugs like what we have been mentioned, nitrofurantoin, cotrimoxazole, which are, can pass through the cord and cause hemolysis. Once the child is born, then, severe hemolysis can occur. Even henna the women know what henna is. Okay, and henna is a very important cause of, in the mother, it passes into the baby, okay, and causes hemolysis. Naphthalene, naphthalene, which is now being used for odor, for urinary odor in urinals, okay, or naphthalene, which is put in the clothes, okay. If the mother is using clothes which has been naphthalized or has been kept, stored, where naphthalene is being used to kill the insects which will eat out the clothes. So if you have a storage with naphthalene, even a clothes like that can induce, pregnant ladies can produce children later on with severe hemolysis. So drugs, mother's drugs, henna type, okay, and naphthalene, all can cause neonatal hemolysis. Okay, so the disease is very easily diagnosed if you suspect it. You have to suspect it. Okay, why is somebody hemolyzing? But if the penny drops and he tells you that whenever he eats fava or food, all right, or he take a drug, a particular drug, his eyes become jaundiced, then this is a giveaway for the diagnosis. But if not, then you have to look into the peripheral blood film. And I would like to remind you that one of the most important diagnostic methods is peripheral blood. You cannot do without a good look at the peripheral blood from types of anemia, microcytic hypochromic iron deficiency, macrocytes, normochromic in the megaloblastic anemia, Heinz body, holy bodies, for splenectomy. So, and sickle cell, you can see it in the peripheral blood. Macrocytes or spherocytes. This is again can be easily seen. Big spherocytic cells. You can see the Hamlet cells in a glucose 6-phosphate, and Hamlet is a cell with some denatured hemoglobin in the middle. Okay, so it's so peripheral blood film is a mandatory. And after you do hemoglobin for a cause of anemia, you have to look into the peripheral blood and to see if the site of the cell are cytic, meaning size, all right, normocytic, meaning the size of the cell is normal. Chromic is the staining of the cell, and the staining here represents the presence of hemoglobin. If it is hypochromic, microcytic, micro meaning small cells, and hypochromic, this is classical iron deficiency anemia. Okay, so normochromic meaning that the staining on the cells are normal, and there are some causes for that, like chronic infection. Okay, the peripheral blood film in glucose 6-phosphate dehydrogenase contains Hamlet cells, which I described, or Byte cells, and Heinz body, Heinz, Heinz body. Okay, so Hamlet cells, Byte cells, or Heinz bodies. These are just denatured hemoglobin, which can occur with many patients are living normal. Okay, if you take the precautions, the diagnosis is the most important thing. Okay, we do diagnose importantly because then at least we can know the prognosis. We know what is going to happen to this patient and what are the conditions which will deteriorate or ameliorate the condition. If you can treat, then it's good. If we can't treat, we can ameliorate and we can help the patient, very much so. So diagnosis is always very important. And luckily, now the diagnosis is becoming very, very easy, becoming uh, um, present, okay? And by electrophoresis, you can know a lot of these abnormal hemoglobin, and even the glucose dehydrogenase can easily be diagnosed by electrophoresis by after suspecting it from the history of hemolysis at certain times, and the presence of these bodies, the Heinz bodies, bite cells or the Hemlit cells. Okay, so electrophoresis can help. So diagnosis is very important. Okay, the coming half an hour, I would like to talk about the cells which are available in the blood and how we can diagnose them, how we can, by measuring how many cells we have, we can diagnose diseases. Okay, these are white cells. These are what we call white cells. In contrast to the red cells, which are the RBCs, we talk about white cells. And these are neutrophils, lymphocytes, monocytes, eosinophils, basophils. These are the normally available RBC, white cells. But you can have abnormal RBCs at certain times, which I hope we'll discuss now. But the up or down of cells going increased or decreased can occur with different diseases. And this is important to note when we are diagnosing. For instance, neutrophils. Neutrophils are the commonest number of white cells because they range from 40% to 70% of the total. By the way, the percentage is not as important as absolute figures. So it is like neutrophilia, all right, can occur in certain diseases like bacterial infection, for instance. But even certain bacteria can cause neutropenia. Okay, fever like typhoid fever and brucellosis and chalazar, which is a protozoan infection. All these can lead to decreased number of white blood cells, which is called neutropenia. So you need to know what is the state of these cells in different conditions. Okay, so they are obviously produced by the bone marrow, because the bone marrow is the machinery or the factory of all hematological cells, be it RBCs, white cells, or platelets. Okay, so it is important. And the bone marrow needs globin for proteins for hemoglobin, and then it needs a stimulant, which comes from the kidney. Okay, that is a hormone. Remember it, and then it needs raw materials, what we call raw materials like iron, folic acid, and others like cobalt, zinc, which are needed in a small amount. But the essential thing is the link between renal failure and anemia is erythropoietin, which comes from the kidneys and acts like a hormone, because a hormone, by definition, is a substance which is produced by one gland to act on another tissue. Okay, like thyroxine, which is produced by the thyroid gland, but it acts on the whole body, including the heart, muscles, and other parts. Like insulin, produced by pancreas, but it acts on the cells for the use of glucose as an energy. So erythropoietin is very important, and luckily now even with patients with renal failure, there is a manufactured erythropoietin which has to accompany any renal dialysis. In renal dialysis, with patients with renal dialysis, they should always have erythropoietin to combat the anemia. Okay, I went to visit a hospital in Sudan with they then have a social responsibility committee which decides on giving donations to places, and I went with Professor Mustafa Khojali to certain areas in the west of Sudan, and we found dialysis. We wanted to support the schemes of dialysis in Sudan, and the doctors telling me that once the patient goes in the dialysis, his hemoglobin goes down, regularly it goes down, okay, to the extent that they develop heart failure. And the question I ask is, are they having drug erythropoietin or not? And they were not having erythropoietin. And that is an area for donation. So we bought some erythropoietin for them, and hemoglobin would have improved, and the quality of life would have improved as well. So erythropoietin is very important. Okay, neutrophils. Neutrophils are the majority of the white blood cells, and it exists in the body in two places. One, circulating, the one which we take from the venous blood and measure in the lab is as a circulating pool. Okay, the second one is the marginal pool. The marginal pool are white cell neutrophils are attached to the walls, to the arterial walls, and this is the marginal pool. So you would have conditions which will shed the marginal pool, the white cells, from the marginal pool to the circulating pool, increasing the level or the number of neutrophils. So that is something which you should know. And the sometimes variation due to exercise. For instance, smoking is one of the biggest cause of increasing neutrophils because it sheds the marginal pool, it decreases the marginal pool at the expense of the circulating pool. Steroids, okay, adrenaline, these are certain drugs, and adrenaline can come with fear, with anxiety, or as a hormone. All these will increase the neutrophils, not by absolute increase, but by decreasing the attached or the marginal pool. Okay, so we have a neutrophilia due to either increased synthesis by the bone marrow, all right, or decreased margination of the cells. Margination is the marginal pool is being decreased. That is to say, the cells are now in the circulation. Okay, so the commonest cause of neutrophilia is bacterial infection. Okay, and if the infection is severe, the bone marrow will try to produce more and more cells. Okay, sometimes it's exhausted and it produces cells and shedding it to the circulation even prematurely. And this is what we call precursor of neutrophils, which are giving you metamyelocytes or myelocytes. These are the precursors, and it is due to the stress of the bone marrow giving you early metamyelocytes. I mean, they didn't have enough time to ripe or to mature. So presence of these metamyelocytes and myelocytes with very high neutrophils, then this is called leukemoid reaction. Leukemia, this is something like leukemia, leukemoid. It's a smaller leukemia. And oid usually is small. If you are a consultant and you are a younger consultant, you are called consultoid, okay, meaning that they are still small. But here, leukomoid is not a frank leukemia. It contains some of the cells of the leukemia, but it is not leukemia. So certain infections can increase the production of the neutrophils to the extent that premature cells are shed away, calling leukemoid. What are these? You have infections, bacterial infections, pneumococcal infections, even tuberculosis at one time it can cause so, juvenile rheumatoid arthritis. And so it is the presence of these cells. And there is a certain criteria to differentiate leukemia from leukemoid reaction. Okay. The margination, decreased margination, that is increase in the total neutrophilia, is, as we said, exercise, post-operative, and post-operative may be that there is increased level of steroids, stress, that all will decrease the margination of the margination pool or marginal pool of neutrophils. Okay, steroids, as we said, renalin, as we said, these are giving you the increased neutrophils, which is not an absolute, but it is because of shifting from one area of neutrophils to the another areas. Okay, there is obviously, apart from infection, and the idea of the infection is because these neutrophils can combat the bacteria, and they can combat the bacteria, circulate it or swallow the bacteria, and at the expense of their death, they die and they cause pyogenic structure, which is the abscess. So the abscess is the end battle of the neutrophils trying to combat the bacteria. Okay, so it is the one reason of, but we said you have to be careful with certain infections may lead to less neutrophils than others, but usually the bacterial infection, pneumococcal and Pseudomonas and Klebsiella, they give you high bacteria. The change of level of neutrophils from one condition to another then can indicate some complication of the disease. As we said, typhoid fever, usually the white cells or neutrophils are low, but if there is a sudden increase in the neutrophils in typhoid fever, then you are talking about a complication, which may be perforation due to complication, which we dealt with, when we talked about typhoid. The terminal ileum, Peyer's patches, can perforate into the peritoneum, giving you peritonitis. By that, the neutrophils will go up. Okay, so there are certain cases where, the change of neutrophils from low to high will give you an abnormality or a diagnosis for complication. Then the proliferation of the bone marrow. Okay, proliferation, the bone marrow is soft, okay, a creamy structure, okay, and it functions because it is healthy. But if it changes structure, then it becomes, deprived of its ability to produce normal cells. Okay, this can be due to fibrous tissue, fibrosis, okay, what we call myelofibrosis, and this is or neoplasia involving leukemias, okay, or even solid cancer in the bone marrow will deprive the bone marrow from producing cells, and this will end up with reduction of all cells, RBCs to platelets, white cells as well. Okay, and so it is chronic again. In chronic myeloid leukemia, there is overproduction of white cells. But here, there is a good proportion of premature cells or metamyelocytes and myelocytes. Okay, so that is neutrophilia. If we talk about neutropenia, which is the other form, which is the opposite form of the neutrophilia, and we go into 1.5 times 10 to the 9 per liter. If it goes below 1.5, then you are neutropenic. They are neutropenic. I would like to remind you that the white cells, the total number of white cells is more important than the percentage. So certain populations, certain genetic populations have lower white blood cells. And in Sudan, you know, this, we are we are the nation, one of the nations which have already a low white cells. So it is important that we should have a national norms. What is the norm of our population before we call it neutropenia or neutrophilia? Okay, neutropenia is important because it may tell that there is a bone marrow affection. Okay, but it is so common that, you know, can occur with a lot of drugs and with autoimmune diseases and in transit from one condition to another. So it is important to read the neutropenia along other tests and along the clinical picture. Neutropenia is, you know, it persists, it is a pathology. It's a pathology and it causes infection. Okay? It causes infection. Neutropenia is commonly associated with cytotoxic drugs and with irradiation. And here, neutropenia can cause neutropenia because we don't have a defense mechanism. With neutrophils, the patient becomes prone to infection. This is why in bone marrow transplantation, you can give irradiation to a 0 level. You wipe out all cells, normal and leukemic cells, okay? Like in acute lymphoblastic leukemia or acute myelogenous leukemia, then you give total irradiation of the cells, and the patient becomes so prone to infection that he has to be nursed in an incubator. And then they will be given stem cells to develop new bone marrow cells. So neutropenia is, you know, it's a dangerous situation where infection can occur very easily if you have a total neutropenia. Okay, what is the commonest causes of neutropenia? Neonatal alloimmune, like rhesus, okay, just like rhesus incompatibility, you get autoimmune neonatal alloimmune neutropenia. It also causes as an autoimmune disease in Feltis syndrome. Feltis is juvenile rheumatoid arthritis. It can also occur in SLE, systemic lupus erythematosus. Okay, if you give B12 to a B12 deficient macrocytic anemia, then you get decreased neutrophils for a while, okay, but then it recovers. Obviously, as we said, if you have an infiltrate of the bone marrow, this will affect all type of cells, not only neutrophils, but it can affect the other cells. Myelodysplastic syndrome, again, affection of the bone marrow, which can give leukopenia. Hypersplenism is a cause of destruction of cells, hypersplenism, and it's not only the neutrophils which goes down, but it is pancytopenia. If you have big spleen, you know, you get decreased amount of platelets, and decreased amount of RBCs and neutrophils. This is what we call pancytopenia. Okay. Again, in varicella, HIV, rubella, cytomegalovirus, rickettsial diseases, you can have neutropenia. So neutrophilia and neutropenia are some indicators of disease in generally, but it has to be put together in the context of the clinical features and on the other test. One of the causes, or many causes of neutropenia is drugs. So always ask if you have an abnormal white cell count, in particularly in neutrophils, then ask about drugs. More often than not, you will find that a certain drug, if it is stopped, the neutrophils can go up. So it cannot be taken in isolation at all. Okay, lymphocytosis or lymphocytes. Lymphocytes ranges between 20 to 40% of the white cells, and the circulating lymphocytes, if you take blood from venous blood and measure the lymphocytes, this is only represent 2% of the total lymphoid population, because the lymphocytes are in lymph nodes in other places which are lymphoid, and spleen is a lymphoid tissue. Okay, so what represents 2% of the total lymphoid population. So it is on transit. It is on transit to other lymphoid follicle. So there is wide variation in individuals, especially children, of lymphocytes. And there is the diurnal variation. It picks up, if you measure lymphocyte count, it picks up at night. It keeps up at night. So these are normal physiological variation, but pathological variation can occur in conditions like infectious mononucleosis, cytomegalovirus, and hepatitis. You remember brucellosis will give low neutrophils, but it can give higher lymphocytes. And tuberculosis is another, especially in the recovery period of tuberculosis, you get lymphocytosis. Okay. And the other things is any lymphoid cancer like lymphoma, non-Hodgkin lymphoma, leukemia, these are causes of lymphocytosis. Okay, lymphopenia may occur, which is low lymphocytes, which occur in increased rate of death of cells, okay, or it can be associated with cytotoxic drugs and irradiation, okay. Again, lymphopenia can occur in HIV, okay, in the latest stage of HIV and influenza. Okay, corticosteroids wipe out lymphocytes. It causes decreased lymphocytes, okay? Not because an absolute drop, but it is redistribution, okay? Redistribution of lymphocytes. You remember lymphocytes are very important in immunity, and in HIV, there is a phenomena of a decrease of certain types of lymphocytes and macrophages, which contains the CD4 receptor, CD4. So the HIV will kill the CD4. The CD4 is the one which is affected mostly. So the immunity will get decreased, and the patient with HIV becomes prone to funny infections like fungal infections, which are not normal in potent patients. Okay, so the CD4 will go up, and the CD8, which is the helper lymphocyte, will go up in HIV. But here, this is a particular disease, which is particular virus which attacks the lymphocytes. The others are, associated drop or because of production and proliferation or whatever. But here it is a disease which is targeting, HIV is targeting the lymphocytes, which is the important part of immunity, particularly cellular immunity. Okay, eosinophils. Eosinophils, just to finish up, I have 5 minutes to go. Eosinophils usually range between 1 to 6% of the total white count. Okay, and it is very much related to innate immunity and hypersensitivity Okay. Commonly, if you talk about hypersensitivity like asthma, patients with asthma can have hypereosinophilia or eosinophilia. Okay, and allergy. If you are allergic or atopic, okay, then this is another cause of eosinophilia. Atopic meaning those who are hypersensitive, like atopic asthma, what we call type 1 asthma, or allergy to hay fever or sinusitis, which will, because of dust or mites, then will give you eosinophils. But in Africa, the commonest cause of eosinophilia is worms, in worms, either intestinal worms or tissue worms. Okay, the more the worm is in tissue, the higher the eosinophilia will become. Okay, so if you have ascaris, which is intestinal worm, tapeworm, even ankylostoma is, and whipworm, all right, or pinworm. All these are intestinal, and they cause eosinophilia, but not as high as in worms which invade the tissue, like strongyloides, Toxocara canis, Toxocara canis, and hydatid disease. These are, neurocysticercosis. These are worms which invade the tissue. And this is why they get very high eosinophils. Okay, in filariasis, you have a lung pathology in filaria, and gives a syndrome which is hypereosinophilic syndrome, which is called Loeffler's syndrome. Okay, this is a state of asthma and a state of allergy with eosinophilia. And if you if you give steroids, especially if there is strongyloides, you get problems because the steroids will flare up the infection. Okay, in normal asthma, you get eosinophils, but not very high. It's mild in normal asthma. Okay, but if it is a very high eosinophils with hypereosinophilia and asthma, then you think of an added infection like aspergillosis. So this will give you an indication as asthma. It may be associated with fungal disease. Okay, with HIV, you shouldn't. If there is eosinophilia in HIV, you have to question that this patient has a worm somewhere. Okay, and unless you treat the worm first, then antiretroviral therapy will not be very effective. So you have to look if there is an eosinophilia in HIV, then look for the cause. And if it is worm somewhere, then you have to treat the worm to get a very good chance for antiretroviral therapy to work. Okay, other conditions for eosinophilia, like Hodgkin disease, and in Hodgkin, if you have eosinophilia, then it's of good prognosis. You remember that eosinophils is part of the immunity. They release granules, all right, and they are associated with innate immunity and hypersensitivity. So the granules of the eosinophils will have something with the immunity of the patient. This is why I said earlier that although we pack all the white cells in one package, then their role and their function are totally different or are very different from one type of cells to another. Okay, with that, we concluded the hematological disorders or hematological diseases in the tropics. And I gave the introduction about the anemia, sickle cell disease, cell leukemia. We dealt with glucose 6-phosphate dehydrogenase, and then we ended up with talking about the indices or the index or the cells of the blood which indicate a disease, okay, which indicate a disease. So with that, we conclude the hematological abnormalities in the tropics. With that, I would like to thank you for being with me, and we see you next Sunday. And I think Dr. Arrow will tell you that these lectures are now going on the YouTube for all those, okay, students of medicine. Anywhere they can look into them and they can revise what is in there. We started with diseases of the tropics, maybe the classical disease of the tropics, and diseases which are related to the tropics because of other social determinants. And then we talked about all the diseases and to see how do they look in the tropics. Thank you very much indeed, and see you next week.